Okay, go ahead.
Okay, so hi everyone, I'm Dyuti Shah. I'm a medical student from India and I'm going to give a presentation on overview of electrodiagnostic studies. So the reason I wanted to do this whole presentation was that almost every day on this rotation here, we ordered electrodiagnostic studies for at least one patient. And I wanted to get a better idea of the scope of these studies and what abnormal studies actually mean. So I'm going to present what a normal study looks like, how it relates to the physiology, what are the different parameters that we are studying. Then I'm going to talk about the abnormal patterns that are seen in various pathological processes. And at last, I'm going to summarize the abnormal studies that are seen in common disorders. An electrodiagnostic study has basically two parts. The first is a nerve conduction study, where we stimulate the nerve and measure the response from either a different part of the nerve or from a muscle supplied from that nerve. And the next part is a needle electromyography, in which we study voluntary activity of the muscle. Electrodiagnostic studies are basically meant to study the peripheral nervous system. So we are trying to confirm the disease process. We are trying to categorize it as neuropathic, myopathic, or a neuromuscular junction disorder. Then we can also assess the severity of the disease and prognosticate the patient. And of course, these studies are only an adjunct to a good history and a physical examination. So first, I'm going to talk about the nerve conduction studies. The first concept that we must remember is that nerve conduction studies only study the myelinated fibers. That means that these studies are not ideal for studying pain or autonomic dysfunction, which are carried by the unmyelinated fibers, as you can see here. So when we do a sensory nerve conduction study, we are evaluating these A beta fibers, which are the cutaneous afferents to the hair and this hair follicles and the skin. And when we are doing a motor study, we are evaluating these anterior horn cells. And as you can see, these fibers have around the same diameter and around the same conduction velocity. But if you will look closely at this table, you will recognize that the fastest fibers are not evaluated in the routine nerve conduction studies. But these fibers are the ones that have the largest diameter, they are the most thickly myelinated, and hence they would be the first that will be affected in the entrapment neuropathies, like a carpal tunnel syndrome. So to evaluate these fibers, we do what is called a mixed nerve study. So we stimulate a mixed nerve and measure the response from a different part of that nerve. The third concept that is important is that of a supramaximal stimulation. Whenever we are doing a nerve conduction study, we want to stimulate the nerve supramaximally so that any response that we get is from stimulating all the fibers in that particular nerve, and any change in the amplitude is not just because some of the fibers are not activated. So when we do a nerve conduction study, we use an active recording electrode that we place on the skin surface, and then we measure the extracellular recording of the intracellular changes that are occurring in the muscle or the nerve with the action potential. And by convention, the negative deflection is taken as upwards and the positive is taken as downwards. So coming to a motor nerve conduction study, in this study, we stimulate the motor nerve at a proximal and a distal point, and then record the response from the muscle supplied by that nerve. So in case of an upper limb, we stimulate the median and the ulnar nerve at proximal and distal points and measure the responses from these muscles. And in the lower limb, we stimulate the peroneal and the tibial at the knee and the ankle and measure the response from these muscles. An advantage of measuring the response from the muscle is that we get a magnification effect. This is because when we stimulate a motor nerve, we are measuring the response from all the muscle fibers that are supplied by that nerve, so that we get a summated muscle action potential. And the end result is that the compound motor action potential is actually 100 times greater than the sensory nerve action potential. So it would be a technically less demanding study. The action potential won't be much affected by the noise that a sensory nerve action potential is subject to. So that a motor nerve conduction study is done first, and then we move on to the sensory nerve conduction study. If you're going to do a sensory nerve conduction study first and we don't get a response, we can't be sure if that's due to some technical difficulties or the response was actually not present due to the pathological process. So this is what a normal compound motor action potential looks like. And we are basically concerned with these 5 parameters, and all of them are quite straightforward to measure, as you can see here, except for the conduction velocity. And that's because we can't just divide the distance from the latency to calculate the conduction velocity, as the latency depends not just on the time it takes for the impulse to travel the nerve, but also the time it takes to travel the neuromuscular junction and the time it takes to depolarize the muscle. So we have to subtract this effect to get a true conduction velocity along the nerve. We do that by subtracting this distal latency from the proximal latency and dividing that value by the distance between these 2 points to get the actual conduction velocity along the axon. And this is the whole reason that we stimulate a motor nerve at 2 points. This is not the case when we are evaluating a sensory nerve, as we'll see in the next slide. Okay, so these 5 parameters and what they actually mean. The distal latency and the conduction velocity represent the fastest conducting fibers. So they give us an idea of the time it takes for the fastest nerve fibers in a nerve to travel to get the response. The amplitude and area tell us about the number of muscle fibers that are activated, and the duration tells us about the synchrony of firing of the muscle fibers. So for example, if there is a demyelinating process, the latency would be increased, the velocity would be decreased. If there is axonal loss and the motor units are decreased, the amplitude and the area will decrease. And if the nerve fibers are affected unequally and they are carrying the impulse at different velocities, we'll get an increased duration of the response. Now getting to the sensory nerve conduction study, in here we stimulate the nerve at a point and then measure the response at a different part of the same nerve. In case of the upper limb, we stimulate the median, the ulnar, and the radial nerves. And in case of the lower limbs, we stimulate the sural and the superficial peroneal nerve. One thing to keep in mind is that in sensory nerve conduction studies, we are stimulating the nerve antidromically. And what that means is that we are stimulating the nerve in the opposite direction to the way a normal nerve impulse carries physiologically. Normally, the sensory nerves would carry the response from distal to the proximal end, but here we stimulate the nerve proximally and measure the response distally. This is because the nerve fibers here would be closer to the recording electrodes and we'll get a greater amplitude of response, which is very important because the sensory nerve action potential is already very low in amplitude and subject to noise. And we measure the same parameters here as in a motor nerve conduction study, and they mean the same things. The one additional parameter that we use here is the peak latency. And this is because there can be some variation in selecting this onset because of this low amplitude. Whereas if selecting the peak is much easier. So in some studies, peak latency are reported as compared to the onset latencies. So this was everything about a normal nerve conduction study. Now getting to some of the abnormal patterns that we can see, and starting first with the focal demyelinating neuropathy. As we have talked earlier, in a demyelinating process, the conduction velocity would be slowed, but the actual response that we get depends on how the nerve is affected clinically. For example, if the nodes of Ranvier are widened and we are having a paranodal demyelination, we'll get a focal slowing. And if all the nerve fibers are affected equally, then we'll either get increased distal latency or slowed conduction velocity. For example, if the nerve is affected here, the distal latency will be prolonged, as you can see here. But since this segment is normal, the conduction velocity would be normal. And if the nerve is affected here, the distal latency would be normal, like it's seen here, and the conduction velocity would be slow. If all the fibers are affected unequally, the responses here would come at different times and we'll get a dispersed response. There's a very important pattern that is seen when the entire myelin segment between the 2 nodes of Ranvier is affected, and that's called a conduction block. So in that case, for example, if the nerve is affected here, if you are stimulating the nerve here, some of the nerve fibers won't be able to carry the impulse downwards, and some of the muscle fibers won't be stimulated. And so the amplitude of response would be lower. and it may be possible to mistake it for an axonal process, but this is not so. And this is actually a demyelinating process that is present between the two stimulation points. And so we have to remember that in a demyelinating process, you can also get a decreased amplitude. Now going to an axon loss mononeuropathy, we know that in an axon loss mononeuropathy, we'll get a reduced amplitude because all of the impulses won't be able to carry on over here. But in here, we also get a very interesting pattern of response when we are stimulating, when we are recording the nerve initially after the injury. In that case, this distal axon does not have enough time to undergo Wallerian regeneration. And this axon would be excitable. And if you will stimulate the nerve at this point, you will get a normal response like it's seen here. And if you will stimulate here, you will get a reduced amplitude. And exactly the same as the conduction block that was seen in the previous slide. So if you're measuring the nerve initially after an acute axonal damage, you may mistake the process for a demyelinating one. And the only way to differentiate that is to measure the response again after a few days. And this is also clinically very relevant to the patient because an axon loss has a more severe prognosis as compared to the demyelinating process. So we have to take care to consider the exact etiology of the process. Coming to a radiculopathy by definition is a abnormal disorder of the nerve roots within the spinal canal. And since the dorsal root ganglion of the dorsal sensory root is located outside the spinal canal, this won't be affected in radiculopathy. So radiculopathy is a preganglionic process. This dorsal root ganglion is a unipolar neuron with a proximal axon and a distal axon. In a radiculopathy, the proximal axon will be affected, whereas the distal axon would be completely normal and it would never undergo degeneration because it is connected to the cell body and it can get all the nourishment it needs from the cell body. So although the patient has a lot of sensory symptoms, has a lot of sensory loss because the impulses can't reach the central nervous system for processing, the sensory nerve action potentials would still remain normal since the axon is excitable and we can get a response distally. And this pattern is very important to recognize in a radiculopathy. Before getting to more like generalized polyneuropathies, there is a normal thing that happens in a normal nerve conduction study, which is the concept of temporal dispersion and phase cancellation. So when we stimulate the nerve distally, the faster and the slower fibers in the nerve, they can carry the impulses at about the same time to the distal recording site. But when we stimulate the nerve proximally, these impulses in the different fibers can increasingly lag behind each other, in which case we'll get an increased duration of response. And because of the negative positive phase cancellation, we'll get a decreased amplitude of the response. So for example, in a generalized demyelinating polyneuropathy, we would of course expect like significant slowing of the conduction velocity, the prolongation of the distal latencies. But if we stimulate the nerve proximally, we will also get a decreased amplitude because of this temporal dispersion and phase cancellation. Whereas in an axonal polyneuropathy, we will get decreased amplitudes and the conduction velocity and distal latencies would be normal. So the normal pattern in a demyelinating process is prolonged latency, slow conduction velocity with conduction blocks. And in an axonal process, it is decreased amplitudes. In nerve conduction study, we can also incorporate a special study like a repetitive nerve stimulation to identify neuromuscular junction disorders. We can stimulate any nerve by repetitive stimulation, but the nerves most commonly used are the median, ulnar, spinal accessory, and the facial nerves. So to understand the concept of repetitive nerve stimulation, we need to first quickly review how the action potential travels along the neuromuscular junction. So when the nerve action potential reaches the nerve terminal, the voltage-gated calcium channels are activated, there is calcium influx, It causes the synaptic vesicles to fuse with the nerve terminal. They releases acetylcholine here, which binds the acetylcholine receptor to generate the end-plate potential, which then causes the. So normally the end-plate potential that is produced in this muscle fiber is much greater than that what is supposed to generate the action potential in here, which is called the safety factor, which will be relevant in the subsequent discussions. The acetylcholine vesicle that is released here, it has enough acetylcholine to cause a 1 millivolt change in this muscle fiber here. And on average, around 60 vesicles are released, which means that around 60 millivolt change is produced here. But the number of vesicles that are released depends on the number of vesicles that are available in this primary store just below the synaptic cleft and the probability of release of these vesicles. And the probability of release is directly proportional to the calcium in this nerve terminal. So when we use repetitive nerve stimulation, we usually use two different rates, which is the slow and the rapid. And the difference between these is that at rapid repetitive nerve stimulation, the calcium successively accumulates within this nerve terminal. Because normally it takes the calcium around 100 milliseconds to diffuse outwards, and this rate is faster than that. So with each repetitive nerve stimulation, the calcium would start accumulating here. So with a slow repetitive nerve stimulation, under normal condition, the number of vesicles in the primary store would decrease, the calcium would remain the same, so the probability of release would remain the same. And thus, because of both these factors, the end-plate potential would decrease, but it would always remain above the threshold and the CMAP would be normal. Whereas in a neuromuscular junction disorder, the CMAP, the end-plate potential at baseline is reduced because not enough acetylcholine receptors are present to produce the adequate response. And with slow repetitive nerve stimulation, the end-plate potential would go on decreasing further and we get a CMAP decrement. So CMAP decrement with slow repetitive nerve stimulation is a very important response that is seen in post-synaptic neuromuscular junction disorders. In a pre-synaptic neuromuscular junction disorder, we'll also see this decrement, but in that condition, the CMAP amplitude at baseline is also decreased because not enough calcium is present in the nerve terminal to release all the vesicles. With rapid repetitive nerve stimulation, there are two opposing factors. The number of vesicles in the primary store are decreasing, but at the same time, the probability of release is increasing because there is more calcium in the nerve terminal. But in the normal condition, again, this does not matter. The end-plate potential is always above the threshold, and we get no CMAP change. In a post-synaptic disorder like myasthenia, this also doesn't matter. This end-plate potential is always above the threshold, and we get no change in CMAP. Whereas in a pre-synaptic disorder, with increasing calcium concentration, we will get increased release of vesicles. The end-plate potential will slowly rise, and at some point it will rise above the threshold. So we'll get a CMAP increment. So to conclude, in like a slow repetitive nerve stimulation, we have a CMAP decrement, whereas in a rapid one, we have a CMAP increment in the presynaptic neuromuscular junction disorders, like Lambert-Eaton. So this was all about a nerve conduction study. Once we are done with the nerve conduction study in a particular patient, we move on to the needle electromyography. We can evaluate any muscle in the body with a needle electromyography, but of course that's not very convenient. So on the basis of the history and the examination and the nerve conduction study, we select the muscles that we want to evaluate. And in a needle electromyography, we insert a needle into the muscle. We measure the insertional activity, we measure the spontaneous activity at rest. Then we ask the patient to minimally contract the muscle so that some of the motor units in the muscle are activated. And we assess the morphology of the motor unit action potential. Then we ask the patient to slowly increase the force of contraction.
Hello.
So that the
Okay, very good. Very good.
so that all motor unit action potentials are activated, and we can evaluate whole of the interference pattern of the muscle. In a needle electromyography, concentric needles are mostly used because they are the most convenient to use. They have both the recording and the active electrode in the same needle. So when we ask the patient to minimally contract the muscle, on the screen we can see a few of the motor units activated, and hence we can assess the morphology. We are basically concerned with 3 parameters here, which are the duration, the amplitude, and the phases of the motor unit action potential. The duration is measured from the initial deflection away from the baseline to the final return to the baseline. The amplitude is the distance between these 2 peaks, and the phases are the number of times this waveform crosses the baseline +1. The most important parameter here is the duration, which gives us the reflection of the size of the motor unit. This may seem a little counterintuitive. We may think that the amplitude actually reflects the motor unit size. But as you can see in this figure on the right here, the amplitude depends on the proximity of the needle to the muscle fibers in a particular motor unit. So if you're closer to the muscle fibers, the amplitude can increase like here. If you're farther away, the amplitude can decrease. But in all of these, the duration remains the same. So we are mainly concerned with the duration when we are evaluating the size of the motor unit. As we ask the patient to increase the contraction during a normal needle electromyography, there are 2 processes that are acting at the same time. One, the patient is increasing the firing of the motor unit to increase the force, and at the same time, more motor units are getting activated to increase the force. And in a normal condition, the ratio of firing of the individual motor unit to the number of different motor units that are firing remains approximately the same, which is 5:1. That means if a single motor unit is firing at, for example, 10 Hertz, then the number of motor units that would be firing at that time would be 2. If they are firing at the rate of 20, then 4 motor units would be firing. And we basically assess the interference pattern that we get to see if there is some abnormality. For example, in a neuropathic process, the number of motor units that are firing would be decreased. And so to produce the same amount of force, the motor units would have to increase their firing rate, which is called decreased recruitment, as can be seen in this B figure. So here the motor units that are firing are reduced. So they have to increase their firing rate to produce the same amount of force as in this upper section. In a myopathic process, the number of motor units are normal. Their firing rate is normal, so the ratio remains normal. But the main abnormality here is that the fibers in the motor units are decreased, which means that the force that a particular motor unit can generate is decreased. And so to produce the same amount of force, the motor units would have to start firing for a smaller amount of force. So a myopathic process does not have a recruitment abnormality as such. It's only that for a smaller amount of force, more motor units are firing. Now, coming to the abnormal morphology that is seen in a neuropathic process, like I said earlier, initially with an axonal loss, there would be loss of motor units because of denervation of the muscle fibers, and we'll get a decreased recruitment. However, as the process becomes more chronic, the denervated muscle fibers would undergo renervation from the surviving motor units to collateral sprouting. So the number of muscle fibers per the motor unit would increase. And since the duration is the best reflection of the size of the motor unit action potentials would become prolonged. And they can have a high amplitude and they can be polyphasic, but that is a more non-specific measure. In a myopathic process, since there is loss of muscle fibers within the motor unit, the duration would be decreased. And the response can also be polyphasic with a low amplitude. Okay, to summarize, this is how a neuropathic motor unit action potential looks like. It has a long duration, it's polyphasic, it can have a large amplitude, and we would get decreased recruitment. Whereas in a myopathic process, we would have low amplitude, polyphasic, short duration motor unit action potentials, which will with early recruitment. So this is about the abnormal needle electromyography findings that are seen with voluntary activity. However, there can be a lot of abnormal spontaneous activity at rest. In a normal muscle, we won't expect any electrical activity at rest. But in abnormal processes, lots of different parts of this motor unit can generate abnormal potentials. And I'm just going to talk about two abnormal potentials here, which is the fibrillation potential and fasciculation. A fibrillation is produced from a muscle fiber. So a denervated muscle fiber that has an unstable muscle membrane can fire on its own and generate these action potentials. And this can usually be seen with nerve injuries or with inflammatory myopathies. Whereas the fasciculation is produced from an individual motor unit. And so we would get like involuntary discharges of the motor unit, which would be irregular. And although this can be a normal finding that can be seen in benign fasciculation syndrome, this is a very important finding to recognize in motor neuron disease and can contribute to the diagnosis. So this is how fibrillation potential looks like. It would be a regular response with a brief spike, and we can lessen it to here, but it usually sounds like rain on the roof. Whereas with fasciculations, since they are produced by the motor neuron, we will see a motor unit action potential morphology. And it would be quite irregular, not like the regular firing that is seen in a fibrillation potential. Okay, so once we can recognize the abnormal pathological process on a nerve conduction study and EMG, then on basis of the distribution of these abnormalities, it's easy to come to the clinical syndrome. For example, if the motor nerve conduction study show axonal loss and the sensory nerve conduction study are completely normal, and the needle EMG has neuropathic findings in multiple myotomes, maybe involving the thoracic paraspinal muscles, maybe involving the bulbar muscles, and we can see fibrillation and fasciculation potentials, then we can diagnose the patient with a motor neuron disease. Whereas if we get similar findings as here, but they're limited to one myotome, in the correct clinical context, we can diagnose the patient with a radiculopathy. And if the motor nerve conduction studies are completely normal, the needle EMG has a myopathic finding, and it affects the proximal more than the distal, then we can diagnose a proximal myopathy. Okay, so this is all. The takeaway message is that electrodiagnostic studies can be very helpful in our diagnosis, provided that we have a good history and a physical examination, and we know what we are looking for in these studies.
Okay, thank you very much.